Welcome, everyone. I'm Dr. Carmen Puliafito. I'm here today. I'm with Dr. Jessica Randolph of the Wagner Kapoor Institute in Richmond, Virginia. Jessica, welcome to Retina Synthesis.
Thank you so much for having me. Happy to be here.
In the March-April issue of Retina Physician, you published a wonderful article outlining the therapeutic pipeline for geographic atrophy and macular degeneration. Uh, It's a wonderful article and goes over many of the uh, clinical research initiatives that are underway. Can you outline, in general terms, the main areas of therapeutic interest?
Sure. The main areas of therapeutic interest right now are the complement inhibitors and the genetic um, gene therapy, excuse me, uh, gene therapy, and then some other types of therapies, including mitochondrial targeted therapies for the treatment of geographic atrophy. The complement inhibitors are the ones that are sort of most in the news right now because those are the two that are currently approved for the treatment of geographic atrophy. And so by interrupting this complement cascade, we can prevent a lot of the oxidative stress and mitochondrial dysfunction that causes the damage that can lead to the geographic atrophy that these patients experience.
So this basically reduces the rate of growth by 20% or so, correct?
Correct. That's what the studies are showing.
Now, what about other investigational complement approaches, such as Promet, the Annexon drug?
Yes, so that one is it's a monoclonal antibody that's targeting this C1q complement protein, and it is really inhibiting the classical complement pathway. And if you remember all the different pathways in medical school involved in the complement cascade, this is only one of the different areas. And so it's a seems to be a more targeted approach than some of the others that are approved now, which are more general. And so the hope is that with this, there will be less synaptic loss and therefore less geographic atrophy that affects the patients.
The study is interesting because they're looking at trying to prevent loss of 15 letters of vision at 12 months. It's not really looking at the area of geographic atrophy. It's an interesting endpoint.
It is an interesting endpoint. And I think these studies in general it's difficult to have a really solid endpoint because some people lose more geographic atrophy, but it's not as much vision and vice versa. And the quality of patients' vision is usually affected in different ways. And so to me, sometimes the patient outcomes don't necessarily match up with the outcome of the trial or in real life, for instance. And so it can be difficult um, to sort of have one obvious answer to what we're looking for. So, although they did do it a little bit different than some of the other studies, I still think it's a reasonable outcome.
Yeah, it is interesting. And because we know with the complement inhibition studies that have gone so far, they really haven't shown improvement in visual acuity. We're really looking at the extent of geographic atrophy as a proxy for visual function.
Right, exactly. And it's
So
not exactly a one-to-one proxy.
it's a big study that's underway. They have 630 patients in a phase 3 study, and the results are going to be out in sometime in 2026. I think this is a potentially exciting therapeutic advance.
Absolutely.
So what about
Absolutely.
mitochondria?
In the mitochondrial range, we have the LMIPRITide, which is a mitochondrial targeted peptide that is currently being examined. And some of the oxidative stress that happens in geographic atrophy can target the mitochondria and cause mitochondrial dysfunction, which then can lead to the dysfunction of the cells and the geographic atrophy. And so by trying to prevent that damage, like with this drug, then it can help improve the oxidative stress and the functioning of those RPE cells and photoreceptors. This one specifically helps to stabilize cardiolipin in the inner mitochondrial membrane and therefore helps to stabilize those mitochondria and prevent the damage. They also did look at some of the functional outcomes in their study to see what to see more of like a real world, end result than just the geographic atrophy change or decrease in change rather.
Yeah, they looked at low luminance vision
Mhm.
and other functional. The phase two trial didn't meet the primary endpoint, but some patients had vision, so they're still going ahead with another study.
Right, right. And I think that kind of goes back to what we were saying a moment ago about how the endpoints don't always match up with the patient experience or the real world effect that the drug may be having.
Well, this is an interesting drug because it's delivered subcutaneously.
Yes, that is interesting. And, it's very different for something like this, and the patients may tolerate that better and not have as many of the side effects and the things like risk of endophthalmitis. So it's an interesting concept. We'll see how it turns out.
Well, and then we have gene therapy. Lots going on in gene therapy.
Yes.
Can you tell me about the CD59 story?
Yes. So the CD59 is an inhibitor of the MAC complex. And so with this study, they are giving in an intravitreal drug that encodes this soluble CD59. And their main outcomes were looking at the geographic atrophy and seeing if that would reverse the changes again and slow down the GA. Um, there are other gene therapy drugs out there. Um, the GT005 drug is a single subretinal injection. And so, in talking about the different delivery methods, there's the intravitreal versus the subretinal injection, and they may have different side effect profiles that are important to consider there. Um, but in general, the subretinal injection was well tolerated, and the majority of the adverse effects were really from the surgery itself and not from the drug. So having an additional surgery, of course, has its own set of risks. But for something that may be effective and really help people, then it could be worth it.
Well, I think the one of the great promises of intravitreal gene therapy is that it's a single intervention. And one of the challenges with complement therapy is monthly or bi-monthly injections,
Absolutely.
which is a tremendous
Absolutely.
treatment burden.
It's a tremendous patient burden. And I think on top of that, the patients don't see the benefit of it as much as with our anti-VEGF intravitreal injections, for instance. And so it's harder for them to feel like the drug is doing anything. And I think for that reason, some patients aren't interested in getting it, or there's a less interest than, for instance, in anti-VEGF injections with wet macular degeneration, where there's this definite improvement in vision that happens most of the time after the injections.
Yeah. But of course, if you have your fovea being threatened by advancing geographic atrophy, complement inhibition is there to slow things down and give you extra time.
Sure. Yeah. I totally agree with you. And I think it's easier to explain to patients that have had one eye go or are noticing the vision changes more. But some patients who aren't noticing those vision changes are going to have a harder time being on board with getting the injections and getting them forever, essentially, um, without having some sort of motivation like the vision loss.
The final area is cell therapy. So what's going on there? There are two approaches. One is the injection of subretinal RPE cells, allogeneic cells, and then there's the platform approach. Uh, can you comment on the subretinal injection study?
Yes, the GT005.
Yes.
Yes. Yes, so that's the subretinal injection, and they're currently in, I believe, their phase 3 trials, and their phase 2 did show good safety and reduction of the GA lesion growth. And this is just a one-time subretinal injection of the gene therapy.
Well, you know, one of the big challenges is trying to restore function rather than just keeping destruction, limiting destruction.
Mhm.
And there's another approach, a platform approach, correct, where they put RPE cells on a platform and inject them in the subretinal space.
Yes. And then they can, from there, work on the RPE.
Regenerative patch technology, I think, is the company working on that.
Yes. Yes. I've heard of that. I don't have the data off the top of my head for that one.
Yeah. No, there's a lot going on in targeted complement inhibition, mitochondrial therapy, gene therapy, and cellular replacement therapy. Uh, do you have an opinion about which of these arenas is most likely to succeed?
Oh, most likely, I'm not sure. My preference is for whichever one is the easiest one-stop shop with the least number of side effects.
Yeah.
Um, I think we've proven that complement therapies can work. I think the gene therapies are the next frontier for a lot of medical diseases, and I so I kind of like the idea of those. But we'll have to see how everything turns out with safety profiles and actual change in vision.
I like intravitreal injection. I think that's something that every retina specialist knows about, can do, and very comfortable with.
Mhm.
I'm excited about gene therapy. The CD59 approach is one that sounds very promising to me. And uh, the complement in the C1 blocker is intriguing as well, but it's monthly injections to improve vision, which is a challenge. And the cellular therapy is promising, but it involves surgery. And in one case, subretinal surgery, which is technically challenging and perhaps prohibitively expensive considering the large number of patients with macular degeneration that are out there.
Right. And that number of patients is only going to keep increasing. So I think that's why I hope it's whatever is the shortest number of treatments required, just because I think that'll be better for patients and overall in general in terms of workforce issues.
Yeah. So on retina synthesis, we'll be covering all these developments as they emerge over the next year or two. It's going to be an exciting period for macular degeneration and geographic atrophy.
Yes, it will. I agree. Lots
Thank,
of new exciting things out there.
thanks a lot, Dr. Randolph. This was wonderful.
Thank you.